Hey everyone, and welcome to The Explainer. I am so thrilled you're here today because, wow, we have a massive, literally industry-shifting topic to break down. We're going to be untangling the extremely complex, newly minted calendar year 2026 CPT code updates for Remote Therapeutic Monitoring, or RTM for short. Look, if you work in medical coding, billing, or practice management, you already know RTM has been kind of this moving target ever since it was first introduced. Well, grab a notepad because the AMA and CMS have just completely rewritten the playbook for 2026. We're going to unpack all of these changes together, step by step, so we know exactly what we're dealing with. Okay, let's dive right into this and talk about why this matters to you right now. The era of kind of vague, wishy-washy billing, yeah, that's officially over. What worked for you in 2025 will absolutely no longer fly in 2026. The new guidelines introduce strict 16-day minimums, brand new time-based rules, and very specific constraints on how we even calculate a billing period. And trust me, if you miss these subtle details, you aren't just looking at a slap on the wrist. You are going to be facing an absolute tidal wave of claim denials.
So here is our roadmap for today. We'll start with RTM basics, dive into the 2026 code updates, walk through the time-based billing guidelines, check out Medicare policy, and then wrap it all up.
All right, moving right into Section 1, Understanding RTM Basics. So what exactly is RTM? Well, as defined by the AMA, it represents the monitoring of a patient's adherence to at-home therapeutic interventions. It's basically about collecting data remotely using medical devices. Think wearable sensors, smart pillboxes, or spirometers. This is a real game changer because it allows providers to monitor a patient's response to therapeutic treatments, like managing chronic obstructive pulmonary disease, right in between their in-person visits. RTM covers reviewing data related to the signs, symptoms, and functions of a therapeutic response, and is particularly focused on the musculoskeletal system, the respiratory system, cognitive behavioral therapy, and just general medication adherence. Now, we really got to clear up a common point of confusion right out of the gate. Actually, scratch that. It's more like a critical distinction. We have to know the difference between remote therapeutic monitoring and remote physiologic monitoring, or RPM. RPM codes are strictly for monitoring physiologic parameters, so that's your weight, blood pressure, pulse oximetry, things like that. RTM, on the other hand, monitors non-physiologic data. It's specifically looking at therapy adherence and therapeutic response. You absolutely have to keep this non-physiologic parameter distinction crystal clear in your mind before you ever assign an RTM code. And that brings us to Section 2, the 2026 code updates. Let's see how the landscape is shifting. So, for calendar year 2026, the CPT editorial panel created entirely new codes specifically for short-duration monitoring. Notice the specific therapeutic systems being targeted here. 98984 handles the respiratory system. 9895 is for musculoskeletal. And 98986 covers cognitive behavioral therapy. These codes are designed to capture device supply for data access or transmissions of just 2 to 15 days within a 30-day period. Previously, we really didn't have a specific way to capture this short-duration data transmission. But now, we finally do. But what about your standard full-month monitoring? Honestly, guys, this is where the biggest compliance trap is hiding. Let's examine code 98976 for respiratory system monitoring. Back in 2025, the code descriptor vaguely stated each 30 days, while the revised 2026 descriptor now explicitly states 16 to 30 days in a 30-day period. So the crucial point here is that a minimum 16-day requirement is now hard-coded right into the descriptor. If you only have, say, 15 days of data transmission, you absolutely cannot use this code. You must drop down to those new short-duration codes we just looked at.
And keep in mind, this standardization applies across the board. Take a look at code 98977, which covers musculoskeletal system monitoring. We are seeing the exact same shift here. That vague each 30 days language, completely gone. It's replaced by 16 to 30 days in a 30-day period. I can't stress this enough. If your tracking system isn't strictly monitoring that 16-day threshold, your claims are going to fail, for sure.
Finally, just to round out these primary device supply codes, code 98978 for cognitive behavioral therapy monitoring gets the exact same treatment. The 2026 descriptor locks in that 16 to 30 days in a 30-day period language. The standard is now uniform across the board. 16 days is the absolute floor for reporting these primary codes, period. Okay, real quick, before we jump into the dramatic changes hitting the time-based billing rules, I want to ask you a quick favor. If you are finding this explainer helpful, please hit that like button and make sure you subscribe to the channel for daily healthcare coding updates. Also, I really want to know what challenges you're dealing with right now, so drop a comment below and tell me which medical coding topics you want us to discuss next.
All right, let's get back into it. Section 3, Time-Based Filling Guidelines.
Okay, so the CPT editorial panel didn't just tweak the device codes, they completely overhauled the RTM Treatment Management Services, or TMS, guidelines. Let's break down this timetable. For 0 to 9 minutes spent in a calendar month, it is not separately reported. But for 10 to 19 minutes, moving into 2026, we have a brand new code, 98979, which is specifically for reporting those brief services of the first 10 minutes. Then, 20 to 39 minutes hits code 98980. For 40 to 59 minutes, you report 98980 plus the add-on code 98981. It is incredibly structured now, no more guessing. Now catch this subtle little wording change because it has massive workflow implications. Did you notice the shift to a calendar month? The guidelines explicitly stipulate that codes 98979 and 98980 should only be reported once in a calendar month, and that's regardless of how many therapeutic monitoring modalities you performed in that month. This completely replaces those old, confusing, rolling 30-day periods. Everything is now tethered cleanly to the calendar month. But here is a truly fascinating catch I noticed in the guidelines. They require at least one real-time interactive communication with the patient or the caregiver during that calendar month for these TMS codes. Now, the AMA's Telemedicine Services Guideline defines real-time interactive communication as using either combined audio-video or audio-only telecommunication. However, none of these specific RTM codes appear in Appendix T. So what does that mean? It means audio-only telemedicine is definitively not an option for RTM. It absolutely must be combined audio-video, no exceptions.
Moving on to Section 4, Medicare Policy and Modifiers. Let's see how Medicare fits into all this.
So in the calendar year 2026 Medicare Physician Fee Schedule Final Rule, CMS confirmed that their Medicare policy completely coincides with the new CPT guidance. However, we have a massive point of clarification to make right here. Even though we literally just talked about interactive audio-video communication, as far as CMS is concerned, RTM is not telemedicine. Let me repeat that one more time because it's that important. It is not telemedicine. Because of this, CMS strictly dictates that you should not use a telehealth place of service code for these services. If you try to use a telehealth POS here, it's basically going to trigger an immediate denial.
Now let's look at how your provider types actually impact the billing. The new RTM codes, 98979, 98984, and 98985, just like the older RTM codes, are designated as sometimes therapy codes. So what exactly does sometimes therapy mean? Well, it means these services can be billed outside a therapy plan of care only when they're performed by a physician or certain non-physician practitioners. If a physical therapist or an occupational therapist is providing these services, a specific plan of care is absolutely required.
And when that plan of care is required, your claim must include specific therapy modifiers to tell the whole story to the payer. Let's run through them. For a speech-language pathologist, you're going to use modifier GN. For an occupational therapist, use GO. And for a physical therapist, use GP. Furthermore, when these are furnished by a therapy assistant, you generally also require modifier CQ for PT assistants or CO for OT assistants. Oh, and remember, when therapists delegate to assistants for codes like 98975 or 98979, those services are strictly subject to CMS's de minimis or 10% standard policy. Keep a close eye on that.
All right, Section 5, the wrap-up. We have covered a tremendous amount of ground today. Let's pull it all together.
So, what's the ultimate crucial takeaway from all this? RCTM is no longer a gray area. With this major shift to strict calendar month reporting, the absolute mandate for combined audio-video communication, and those hard-coded 16-day minimums for standard codes, the margin for error has basically vanished. So I'm going to leave you with this question. Is your practice's billing system and workflow genuinely prepared for this 2026 scrutiny? Really think about that. Review your systems, talk to your team, and make sure your tech tracks exactly 16 days. Thank you so much for joining me today. Don't forget to like this explainer, subscribe to the channel for daily coding updates, and leave a comment below letting me know what topic you want to dive into next. Keep learning, keep adapting, and I'll see you in the next explainer.